go start with a little bit of a case example on this one to get through this. So starting out with 72-year-old female. She was found down minimally responsive. Because of that, they intubated her in the emergency department for airway protection. You got paged, all the ED resident told you as well. There's blood on the CT scan, and I'm not sure where, but there's just blood. You don't know anything about her past medical history, but they're not aware for being on any blood thinners or anything major. And you go, you see her. You haven't seen the image yet. This is her exam. So her eyes are opening to stimuli, or so it's like external rub, tactile stimuli, and she is going to be flexure posturing is the best exam you get. So GCS is 6T. Anyone want to, so we're talking about subarachnoid hemorrhage. We haven't seen the picture yet, but there are a few things one thing that you want to talk about that's purely based on the physical exam with subarachnoid. Does anyone know what that grading scale is? There's two big grading scales we use in subarachnoid, but anyone know what the grading system is that's based on their physical exam?
Hess.
Yeah, your Hess. So the Hess is, so this is the original paper. And I think it's sometimes helpful to look back at some of these, it's something we frequently talk about, but this is a paper from the 60s. So although we still use some of the terminology from it, I think a lot of our understanding of aneurysms and subarachnoid hemorrhage has changed some of that. And so we kind of have to rethink how we clinically utilize this scale, even though it can still be very helpful for us. So look back, it was a fairly well-designed study. It was moderately sized with 275 patients. It's important to note that the purpose of this study was to look at their surgical risk and determine essentially, when are you going to treat someone with a subarachnoid hemorrhage? And the idea was people who come in, here's the grading right here. So I'll talk a little bit about some of the limitations of the grading, but grade 1, pretty much asymptomatic. They may have a little bit of some neck stiffness, mild headache, that's it. Grade 2, a little bit more of a headache, but they're not sleepy at all. And they may have a cranial nerve palsy. So say you have a patient that's got a headache, sudden onset thunderclap headache, and a third nerve palsy. Anyone know what type of aneurysm you're going to be worried about with that?
PCOM?
Yeah, PCOM. The third nerve travels right in the vicinity of the PCOM. Good job. So that would be someone who's a grade 2. Grade 3 is when they are drowsy and they may or may not have some focal deficit. I think this is between grades 2, 3, and 4 can kind of blend together. You have to decide what's the difference between drowsy and stuporous. Although in a grade 4, they're going to usually have some sort of motor deficit. And I kind of think of decerebrate posturing as kind of they are posturing or they're not posturing. I'm not really sure what they mean by early. And then grade 5 is someone who's posturing. So this patient we went to before, anyone want to go at their Hess?
Fine.
So they'd be close. So this is flexure, which is not extensor posturing. So you got to remember the different types of posturings. This would be a grade 4. So maybe that's what they're saying, early decerebrate, but being flexure versus extensor. I don't really know, but that would probably be considered more of a grade 4. Now, the whole purpose of Hess was to get an idea of surgical risk. And essentially what they're saying, what they found is that people with high, it's also important to know there's no grade 5s in their series. But people with high grade, meaning 3 or 4, had a very high risk of dying if you intervened early. So what they recommended was you didn't actually intervene or operate on the 3s and 4s. You operated on the 1s and 2s. The 3s and 4s you stabilized until they clinically improved, and then you would consider operating. That's not necessarily how we really approach aneurysms anymore, but we still frequently use the Hess classification. So it's important to know that the reason we use it has changed a little bit. In general, we still think of it as like a morbidity predictor, but this is not relevant anymore because how we manage aneurysms has completely changed since the 60s. In the late, let's see here, I think it was in the late 80s, Drake proposed a different grading scale, something called the World Federation of Neurosurgery Scale, neurological surgeons, excuse me. I think this is actually a better scale. It's not quite as widely used here at Buffalo. We tend to still stick to Hess a little bit more. I tend to like the WFNS more because it's a little bit more objective. You're not looking at the difference between what's drowsy versus stuporous. It's based purely on GCS and a motor deficit. And I think it takes out some of the ambiguity. And what you find, there's this, a study in neurosurgery, excuse me. They're looking at, now it says H and K, that's Hunt and Kosnick, which is essentially a Hunt-Hess scale, but, and actually technically this right here is Hunt and Kosnick, because Hunt-Hess was just 1, 2, 3, 4, 5. When you added 0 for no subarachnoid hemorrhage, and then that's 1A, that's what makes it a Hunt and Kosnick scale versus a Hunt-Hess. So a little sidebar there, so that's why that doesn't say H and H. But you look here, you look at how this worked, and there's a pretty good concordance between the two. But what you'll find is that Hunt-Hess kind of overcalls some that would be a 2, or the 2s tend to be a little bit overcalled. You have more 2s in World Federation of Neurosurgery, in Hunt-Hess, and it overcalls the grading a little bit for the 2s and 3s. I find it, just like I said, a little bit more straightforward when you're using the World Federation of Neurosurgery. But I think either is fine, and most people are going to ask you about Hunt-Hess. All right, so now let's get to some pictures because that's the good stuff. So this is a patient we took care of a little while back when I initially made this talk. Let's see, Andrew, do you want to describe this head CT for us?
So the axial coronal CT.
And sorry, can you guys hear Andrew?
Yes, we can.
All right, good.
And it looks like there's subarachnoid blood, and then I actually don't know what's on the right.
Yeah, all right, so we can go through this. So this isn't going to be your absolute classic subarachnoid hemorrhage picture, and I kind of picked it for that reason to let you know that not every subarachnoid and many subarachnoids are not the perfect star-shaped blood in the basal cisterns. Now you do notice some blood here. It's towards the basal cisterns, kind of in that star-shaped pattern. Now we're not maybe at the perfect cut, but what you'll notice here, there's a lot of blood, intraventricular blood. So this is down to the 4th ventricle here. You can also see on the coronals extending into the 3rd ventricle and up into the left lateral ventricle. And you have significant dilation of the ventricles. So there's an obstructive hydrocephalus, likely from this intraventricular hemorrhage. And you can almost imagine that there's what's called casting. You can imagine this patient bled into the ventricles, that blood clotted off, caused obstructive hydrocephalus, and then all of a sudden it started expanding around that. And so this is almost a cast of what the 4th ventricle and what the 3rd ventricle looked like at the time of the hemorrhage. So that's what you'll see when someone refers to a casted ventricle. So this person is pretty sick. So I'm going to show you some pictures, and then we'll kind of talk about what you want to do with this in the acute phase and then over the next couple of days. Pretty high level, general, and some of the generalities. And if anyone has any questions, like feel free, like I said, interrupt me, ask questions, challenge me if I say something you don't think is right, because that's very possible. You know, I'm not perfect, call me out. We can all learn something here. So we get an angiogram, and let's see, Emma, do you want to tell me what type of injection we have here?
To me, it looks like I can see the ICA mostly curling up at the bottom, and I don't really see ECA branches behind that C1 portion. If that makes sense, like I see the C1 circles, and I see no branches all coming off that are behind that, so I think it's an ICA.
Correct. What side?
It's
Nope. So you have this. I guess it's not clear. There's a break right here.
Oh, okay.
So this is your. Oh no, got ahead of myself there. This is a AP. This can be lateral ICA injection. And what kind of aneurysm do you see? Or do you see an aneurysm?
I see something.
Where do you see it? Describe some abnormality.
I think it's not like. I think it's out of bifurcation. I think it's out like one of the branching points, but sometimes it's hard to tell because if they're looking at an angle where like there's an overlap between 2 sections, that it is an aneurysm.
It's a good point. So it's a little bit of a trick question. I would say it's hard to say. So you can for sure say there's a PCOM aneurysm here, but this looks a little abnormal as well. So this is where you need to look for more vessels. And so here's a little bit better view. You can clearly see this boot-shaped PCOM aneurysm here. Yeah. You can see a cavernous aneurysm here, and you don't see it quite as well. This picture's not perfect, but there's also an ophthalmic aneurysm as well. So this lady had 3 aneurysms that, based on the imaging, it looked like it was the PCOM that was the ruptured side. All right. So now we've got a Hunt-Hess 4 rupture. You know she's got evidence of acute hydrocephalus. on her imaging. So let's see. Anyone that's not part of the UB group here from the call want to weigh in on their thoughts of what's your first step in managing this? And if you don't want to be called out, that's fine too, but we'll get a second if anyone else wants to step in. What are you going to do? What's the first step?
Well, I would say that first of all, to stabilize the blood pressure.
Perfect. Yeah. Thank you, Miguel. I appreciate you talking up. So the first step is in this, and I kind of break this into the first 24 hours and then the next couple of weeks. So stabilize, you mentioned the blood pressure, but in general, just stabilize the patient. And this is true when you're taking exams in medical school and exams in residency and in real life. Never forget your ABCs. It's really easy sometimes in neurosurgery just get focused on the aneurysm and forget everything else that's going on. And I think one of the hallmarks of, once you really are starting to become into your own as a neurosurgeon is taking that step back and kind of detaching from the situation, looking at the whole picture and making sure you're doing the right thing for the patient from a global view. And for a lot of these patients, especially the acute ruptures and the severe ones, you can't forget the ABCs. Now, those patients are already intubated. And so then you got in their breathing. I didn't go through the labs, but say their pH is fine, that we're not hyperventilating or hypoventilating or anything like that. And you want to think about circulation. So in this sense, they do have a bleed, but they're probably not. Most of the time they're not actively bleeding, although sometimes they are. Then you want to think about blood pressure. So blood pressure is a little bit of a tricky thing because the paradigm changes a little bit when you're managing subarachnoid hemorrhage. So the first 24 hours is stabilizing them. You get them in the ICU. And in general, you want to secure the aneurysm within 24 hours of it rupturing. Because in the first 48 hours, the thing that's going to kill this patient is going to be re-rupture. And when someone re-ruptures, it can be devastating. That being said, someone comes in, middle of the night, it's appropriate. You can say, you know what, I'm going to stabilize this patient. I'm going to put him in the ICU, and we're going to plan for intervention first thing in the morning. It doesn't necessarily have to be tear down the doors of the operating room or the angio suite and be treated right away. You can have a little bit of time. So you get to make sure their ABCs are okay. You get them in the ICU. And then the next decision is whether or not the patient needs an EVD or an external ventricular drain. And the purpose of external ventricular drain is twofold. If they have acute hydro, it's to treat the hydro, and then it's also just to overall monitor the ICP. Now, people have a little bit different approaches to this. I wouldn't say there's any perfect algorithm for how to decide whether to do an EVD. Here at UB and a general cutoff, if there's any concerns on imaging for signs of hydrocephalus, regardless of their exam, that's going to be probably an indication for an EVD. And then in general, a Hunt Hess 3 or higher, we routinely will put in an EVD, regardless of whether or not they have signs of hydrocephalus on their imaging, because in those are patients, if they're starting to get drowsy, we're worried about global increased ICP that you may not necessarily see with just hydrocephalus. And so we want an ICP monitor and be able to intervene if that ICP starts going up, whether that's with hyperosmolar therapy, draining off CSF, or in extreme cases, if you have to do a craniotomy to give some more, or craniectomy, excuse me, to give some more space. And we're also saying in terms of blood pressure, in the first 24 hours or really until the aneurysm is secured, you do want to keep the blood pressure a little bit on the low side. Now, you don't want to drop too low, but in general, you don't want to let them be too hypertensive, MAP less than 70 or systolic less than 120. The idea behind this and whether or not it's completely validated is you don't want to give too much pressure to encourage a re-rupture of the aneurysm. And then the other thing that you need to start absolutely within 24 hours, although it's more of a long-term thing, is the nimodipine. And this is like one medication I do give a talk, show the exact dosing. And the reason for that, and we'll get to in a minute, is that there's one of the few things we have in neurosurgery where there's really level 1 evidence that you need to give the nimodipine to help prevent cerebral infarction. The other thing you routinely will start as an anti-epileptic. This is variable what people use. We tend to use Keppra here in patients who don't have a seizure history and have not been actually presenting with seizures, excuse me. It's less well studied than something like Dilantin, but it's easier to dose and you don't have to follow levels. So we tend to start with Keppra. And then, like I said, securing the aneurysm. Now, what to do endovascular open surgical? I think it's a whole talk in itself. I'm not going to get into too many details about that because there's never really a clear-cut answer to that. There are things about the aneurysm morphology, the patient's age, how severe they are. Oftentimes the higher grades, we don't want to take them just for the surgical risk of anesthesia and everything. So we may be a little bit more aggressive on endovascular. It depends even on a morphologically, an aneurysm that morphologically is potentially better to be treated with open surgical ligation. So that's a very complex decision-making process. And it also has to do with the expertise of the site of where the patient shows up. Here at UB, we're fortunate that we have 4 dual-trained vascular neurosurgeons. We tend to be pretty endovascular heavy. That's kind of our default, but if a patient needs it to be clipped, we are not shy about that either. So then after that first 24 hours, you got them stabilized, the aneurysm secured, then what's next? So 48 hours after the aneurysm ruptures and once it's secured, Devin, what's the next thing that you have to really worry about in subarachnoid patients?
Rebleeding.
So 48 hours out, aneurysm secured. You're not as concerned about rebleeding.
So after being treated, it's not.
So the next thing you always want to watch out for is vasospasm. So routinely our practice here, and there's going to be variation to this, we almost universally keep these patients in the ICU for 2 weeks at a minimum after the rupture for vasospasm watch. Minimum of a week, usually 2 weeks. The biggest window is going to be in that 48 hours to 7 or 8 days. By 12 to 14 days, the risk of vasospasm is severely diminished, although it can be seen outside of that. And then they have to be on nimodipine for 21 days because that's the way the trials were set up. So I talked about nimodipine here. So there was a study, I have the reference down at the bottom here, back in the late 80s for looking at nimodipine in rupture. And what they did is that dosing the 60 milligrams Q4 for 21 days. And it showed the cohort was randomized controlled trials, but the cohort that got the nimodipine had a 22% risk of cerebral infarction, whereas those who did not get it had a 33% risk of it, which was statistically significant. I don't, off the top of my head, recall the p-value, but let's go a little back to, say, some step 1 epidemiology type research here. Andrew, if I went from 33% to 22%, can you walk me through how you'd get the number needed to treat to prevent 1 cerebral infarction? And if you can't, that's okay. If anyone wants to flex their math muscles here, let me know. This is an important thing to remember, and it's one of those things someone might talk you or kind of quiz you on. And it's one of those fairly easy math problems that you should remember the calculation.
No, it's like 1 over.
It is 1 over, so it's 1 over the absolute risk reduction. So you gotta remember it's absolute, not relative. Now in studies, often, especially with small differences in effect, they like to report the relative risk reduction, but you wanna look at the absolute. So the absolute risk reduction here is 22% from 33%. So that's an absolute risk reduction of 11%. So you do 1 over 11% is between 9 and 10, be the number needed to treat, which is a fairly robust effect. Now, granted, it's important to note that when you look at this study, some of the criticism of it is that they looked at both treated and untreated aneurysms. It was all comers, and this was also before the advent of endovascular intervention for subarachnoid hemorrhage. In some subsequent trials, the effect had not been nearly as robust, and they hadn't found effect with other calcium channel blockers. It's really the only thing we see is nimodipine. So I think it's one of those. I think the effect is probably real. We should definitely, there's evidence that we should give it. I don't necessarily know if it's as effective as the initial trials may have demonstrated. That's the one thing. And then the reason you want them in the ICU is, one, oftentimes patients have an EVD, so they're going to need to be in the ICU for that. But they're just going to get more frequent neuro checks and monitoring their vitals, and really any change, unexplained change in their exam, their vitals, they also, they're hypertensive, hypotensive, really anything should warrant investigation in vasospasm, especially in that first week after a rupture. Well, many hospitals, including us, we do routine what are called transcranial Dopplers, which is essentially an ultrasound that measures the velocity of blood flow through the internal carotid artery as well as the MCA. Unfortunately, a lot of patients don't have good bony windows in their head to be able to measure it, but if they do, that gives you an idea of, if what you can do is look at either the absolute velocity in the MCA, or you can look at the relative velocity of the MCA and compared to the internal carotid. And so as the velocity goes up, that's a sign that the vessel is becoming more constricted or narrowed, which is exactly what's happening in vasospasm. So the cutoffs we use for transcranial Dopplers in general, we tend to be a little bit more heavy on the mean velocity. So greater than 200 centimeters per second is considered vasospasm, whereas there's this other thing called a Lindegaard ratio, which is looking at the ratio between the MCA and the internal carotid. And most people will say greater than 6 is significant and severe spasm, 3 to 6 is mild spasm, and less than 3 is normal. What you do, how you treat that varies also a little bit hospital to hospital. In general, you only want to treat symptomatic vasospasm. We'll get into the rates of radiographic versus symptomatic here in a minute, but there are different ways. If someone's symptomatic, has signs of vasospasm, usually the first line treatments can be intra-arterial verapamil, which is a calcium channel blocker, or you can also do a mechanical angioplasty where you go up, put a balloon in the artery and open it up. The other thing you always want to recommend or mention is monitoring for electrolyte abnormalities. So anyone want to comment on, what the most common, sodium we always watch, both hypo and hypernatremia. Specifically in subarachnoid hemorrhage, we'll worry about hyponatremia. So what are the two most common causes of hyponatremia in a subarachnoid patient?
That's ADH and cerebral salt wasting.
Perfect. It's good, and it's really, it can be very difficult to determine what's going on. And in fact, based on their laboratory values, essentially SIADH and cerebral salt wasting can look the exact same. The best marker for differentiating someone is their fluid status. Are they volume down, or are they either euvolemic or volume up? And unfortunately, that is very hard to monitor clinically, but that's the best thing you can do. And the reason it's really important is because the treatment is exactly the opposite for SIADH and cerebral salt wasting. In SIADH, you volume restrict, although we'd be very careful about that in rupture patients because we don't want to get them too volume deplete because that could throw them into vasospasm, whereas cerebral salt wasting, you want to hydrate them. The other thing we don't talk about, I didn't mention on the slide for vasospasm prevention, oftentimes you'll hear this triple H therapy, which stands for hypertension, hypervolemia, and hemodilution. That's kind of fallen out of favor a little bit. Usually more people talk about making sure someone's euvolemic than really pushing their volume status. And we usually don't push blood pressures unless someone becomes symptomatic in vasospasm. So as we talk about vasospasm, there's another scale that we talk about frequently, something called the Fischer scale. So I think if you guys were in on the talk with Dr. Davies the other day, he mentioned this briefly and how he doesn't really put a lot of emphasis in this. And I'll kind of go over a little bit why that is. So Fischer scale is completely a radiographic finding, looking at how much blood there is and where it is in the head, and getting an idea of how that correlates to risk of vasospasm. So this is from the initial study. It was fairly small. And does anyone know what that study showed? I'd be impressed if you know like all the specifics, but in general, what it showed? That's okay. So what it showed was essentially grade 3 was the only one that was strongly associated with clinical vasospasm. They didn't even actually have vasospasm in the other ones. But if you looked at radiographic vasospasm and kind of added this to the side, you can see there's a lot of asymptomatic vasospasm in these different grades, but it's not really a great grading system because there's not a lot of difference between, well, 1, 3 is higher than 4, and there's not really a big difference between 4 and 3, and there wasn't any significant difference between 1, 2, and 4. So, that's what Dr. Davies was talking about. It's not as clinically useful. So several years later, it was addressed, this kind of thing. So someone created what's called a modified Fischer, which you can see how that is here. The big thing there is that instead of just having IVH, meaning it's automatically a 4, in the modified Fischer, you can have IVH as a grade 2 if it's diffuse but thin subarachnoid hemorrhage, regardless if there's IVH. That'd be a 2. And what this did, this is a pretty large retrospective review of 4 placebo-controlled trials, large sample size of 1,300 patients. And what it showed now is that, so this is the way to read this is, the grade 1 is the baseline. And then if you go, what are the odds of being in clinical vasospasm if you're a grade 2 versus a grade 1, a grade 3 versus a grade 2, a grade 4 versus a grade 3. And you'll see that all of these, where it did go up, was statistically significant. But some of these, some of these odd ratio 1.02 being in the confidence interval, yeah, it may be statistically significant, but is that really clinically significant? I'm not sure. And same with a grade 3, but there's a little bit more validity to having this modified Fischer. So I would definitely, I would say this is a better scale than the Fischer. The one thing is if you're reporting it in your notes or talking with an attending or someone else, just make sure when you give someone the Fischer scale, if you're reporting the modified, just say that it's the modified Fischer so they know what you're talking about. So that's a lot of talking about words on a slide and different studies. Let's get into some of the stuff you want to see. That's going to be pictures of aneurysms and things like that, where we can really learn something here. What you're going to see when you open a textbook, most textbooks looking at aneurysms, you're going to see some diagrams like this, and it says, okay, well, here is here is an ACOM aneurysm, here's an ACA aneurysm, here's an MCA, here's a PCOM, and here's a basal apex. Oh, by the way, there might be a little pica aneurysm there. And they're going to tell you some of the incidents of how frequent these occur. Now, this is important, but this picture, you're never going to see this picture. This is really only helpful to conceptualize how the circle of Willis works. It doesn't give you any idea of how these aneurysms actually look. Where when you're clinically involved, you're going to be getting a CTA or an MRA or an angiogram, and you need to look at that picture and get an idea of what kind of aneurysm this is. So that's what we're going to do now. I'm going to go through what I call my aneurysm rapid fire. And what's very helpful, now this is not a perfect rule, but most aneurysms, especially the very common ones, so your ophthalmic, your superior hypophyseal, your PCOM, your ICA terminus, basilar apex, they all tend to point in a specific direction. And if you can get an idea of what direction an aneurysm, where it's generally located, so is it anterior circulation, posterior circulation, if it's anterior circulation, is it ICA or MCA or ACA, and then how it's pointing, you should have a pretty good idea what type of aneurysm this is. So let's go through some of those. This is, I really think, kind of the most useful learning points of this talk today. So we'll talk here. Miguel, you spoke up a little bit earlier. Do you have an idea, or first off, let's say, what kind of injection is this?
So this looks like a left internal carotid injection.
Okay. So pause it there. It's right-sided. So once again, I should probably put a bar here or something so you know that this is two views, but it is internal carotid. The one thing that's helpful, and like I said before, if you guys are here, that unfortunately it's a digital subtraction angiography. So you're digitally subtracting the bones, so you don't have all of those landmarks to help you. And the other thing can make it confusing. Oftentimes when you're looking at angiograms, the way that the software is set up, sometimes the nose is pointing to the left and sometimes the nose is pointing to the right. The way our software is, we essentially always have our AP on the left side and we have our lateral on the right with the nose pointing to the left. So one thing that I was taught by Dr. Hopkins and how to read these angiograms is where is the nose? If you know where the nose is, then you can figure out what you're looking at. So in an AP, your nose is going to be here, and your lateral, your nose is here. So this is looking at the patient. It's coming up the right side, so the ear's over here, nose here. MCA, A1, ACA. And then the same thing here, we have our ICA, you have your ACA coming up, and then your MCA vessels coming back. But, all right, Miguel, do you see the aneurysm? It's okay if you don't.
I think I would see an aneurysm in the posterior communicating portion of the ICA.
Perfect. Okay. So right here is our aneurysm, and you are correct that it's a PCOM. So can anyone tell me, so on the lateral, which direction is the aneurysm pointing? Is it pointing anterior? Yeah, it's pointing posterior, and they also point inferior. And then on the AP, it's not as well shown up, it's a little bit here, but classically, PCOM aneurysms, the dome points inferior and lateral. All right, so you see an aneurysm in kind of the supraclinoid ICA pointing inferior and lateral, 9 times out of 10, or probably even more than that, it's probably going to be a posterior communicating artery aneurysm. All right. How about this one? We'll go with Emma. It's a little bit more subtle. I think we did talk about this one. I may have shown this picture on Monday, but do you see the aneurysm? And if you don't see it, it's a little more subtle.
Like, I think I might, but I'm not sure if my brain's playing.
Well, actually, let's go back. What kind of injection?
There's no brain.
So it's a little bit sloppy. There is
Oh,
probably
it's
some
right down
external
there.
branches down here.
Yeah, it's
So it's going to be a common, but you're not seeing much of that filling. It's very possible that this was an attempted, I don't remember, attempted internal carotid that had some reflux into the external. That's why you're not seeing robust filling of the external and the lateral.
Yeah.
But okay, so where do you think you see the aneurysm?
It would be the C4 segment, I think, on the AP. Like there's this darkening there, but
So C4, what do you mean by C4?
maybe like cavernous segment.
So cavernous segment is right here.
Yeah, on the AP, I feel like I see like a
So
black dot, but I don't
yeah, so
necessarily see
cavernous on the AP,
lateral.
cavernous on the AP is deceiving because you have this looping on itself in that plane, so you're going to see some double densities.
Right.
But when you come around here, you get to, this is going to be your clinoid segment, and you get to your ophthalmic artery right here. You see this superiorly pointing aneurysm. Doesn't show up quite as well on the AP because like it's hidden in the double density of the cavernous, but a anterior, aneurysm in the paraclinoid or supraclinoid ICA region, superiorly pointing. It's gonna be an ophthalmic artery aneurysm. So that's very classic. Whereas, Randy, what kind of injection and where do you see an aneurysm on this one?
So this looks like a right common carotid injection, and the aneurysm is located at the superior hypophyseal artery,
Perfect. So it's a superior. So which direction is it pointing?
laterally. Oh, sorry, medially.
Yeah, medially. Yep. Nose is over here. So you have your internal carotid. This is almost the exact opposite of the ophthalmic. Now on the lateral, you don't really, even though this is a fairly sizable aneurysm, you can definitely get lost and not really see this in a pure lateral angiogram because of all of the curving, the vasculature here. But you look at an AP, you see this clearly medially pointing aneurysm. Paraclinoid or supraclinoid is really technically in the ophthalmic segment of the ICA. That's going to be your classic superior hypophyseal artery aneurysm. All right. We'll go with Devin. What kind of injection is this?
So this is a left-sided common carotid injection.
So no. That's okay.
Sorry, it's left-sided.
No, it's okay. So we haven't looked at this injection quite as frequent. So this is a little bit harder to spell. You have our AP and lateral. This is actually going to be a right vertebral artery here coming into your basilar, and you have your PCAs going up. You have your SCAs. You don't see the AICAs quite very well there, and then you have, so there's your AICA there, and then you have, remember, this is going to be your pica. So we talked about that before. You have your anterior medullary segment, your lateral medullary segment. You have your tonsillar medullary segment, and then your telovelar tonsillar segment, and then your cortical segments of the pica. So this is actually a pretty classic pica there. But so now knowing that this is a right vertebral artery injection, where do you think what kind of aneurysm is this?
So it looks like a basilar aneurysm.
Yeah, exactly. Basilar apex aneurysm. It's a pretty nasty one. It's also got a little daughter bleb here. This is a very high risk aneurysm. All right. How about we'll go back to Emma on this one?
So
What kind of injection?
this is a right common.
Good, right common, because down here you're again seeing some of those external branches that are, even though you don't see it, are kind of muddying the pictures a little bit also on the AP. So good, common carotid. And where do you see the aneurysm?
I feel like I see it around the C67 segment. There's like a bleb on here.
So, okay, so what's, yep, bleb right here. So what structure is this?
That is the, no.
What vessel is this?
Bases.
Good, all right, so this is your A1 segment. What vessel is this?
MCA.
Good. So what's this point called?
Oh, it's scroll.
So it's your ICA terminus,
Yes.
right? And you have an aneurysm coming right off the top of that. So as an ICA terminus aneurysm, you can see it right here on the lateral. Sometimes ICA terminus can be a little bit hard to appreciate on the lateral because if you have a really tortuous ACA or MCA, you'll get hidden in the double densities. And really looking at aneurysms, when you want to get the best pictures of them possible, you're typically not using a straight AP or a straight lateral. You're going to be using oblique views to look at the necks and give you the best possible image of these, because of all of the tortuous vessels around there that can obscure it. And oftentimes it's not just one classic thing. You'll take a quick picture, adjust your views a little bit, take another one, or we often are doing 3D spins, then you can do a reconstruction and essentially look at the entire aneurysm in any view you want. All right. How about this one, Andrew?
So the left ICA.
Left ICA injection. Got you can see our guide catheters up real high here. Good. So it's a little more challenging, but what?
Is that like an aneurysm right there coming up ACA or no?
Where are you pointing? Or sorry, describe to me since you can't point.
It's like right off the bifurcate. It's like right.
So the A1 is right here.
Okay, then right before.
Right.
Yeah.
Here. So yeah, that's an aneurysm right there. Good. Okay, where now you always want to look in two views. So it's easy to get trapped in one view, but you always want to be looking at both pictures and get an idea of where you are. So think about where that probably is on the AP, and then you go to your lateral image and tell me, I'm going to start following the ICA up and tell me when to stop when you think we're in the general vicinity of that aneurysm.
I don't know if it's right there, like up above it, more that big.
This?
No, when you follow
this?
Yeah, right there.
No. You were right in saying here, but it's actually this right here. Now this one's going to be a little more challenging. Your initial thought, this is kind of, say, a ophthalmic, maybe communicating segment of the ICA, and you say, oh, this is inferior, somewhat inferiorly pointing. Maybe that's a PCOM aneurysm, but you have a pretty robust PCOM here. So it's actually quite nice. You can see the PCOM. You can imagine the basilar actually will come up here. See, there's a little change in the caliber of the vessel. So this is the extent of the PCOM. Now this is the P1-2 junction where it becomes P2 here. So it's not PCOM aneurysm. The other reason you know it's not a PCOM aneurysm, and you'll want to remember which direction to, so they point inferior, but where do PCOM aneurysms also point? Inferior and
Posterior.
And lateral.
lateral. Perfect, lateral. And you correctly, Andrew, you correctly pointed to the aneurysm on the AP. What direction is that pointing?
Medial.
Medial. So you combine those things out. That doesn't make sense. It's not going to be a PCOM aneurysm. Those are very rarely going to be pointing medial. And it's probably not far enough back. So now you're saying, okay, maybe not the communicating segment. Maybe this is the ophthalmic segment pointing medial. What type of aneurysm do you think that would be?
So then it's
Superior hypophyseal. Yep, exactly. And it's a little bit harder because I don't have 3D recons on this, but if you can imagine, actually it points medial and then the dome kind of blobs out more inferior, which is a little atypical for a superior hypophyseal. That's probably the best way to label this one. All right. And how about this? Randy?
So the injection looks like a left common carotid.
Left common carotid, perfect. You have the ICA and the ECA vessels filling, perfect. And I actually gave you a little break here, so you know that's two different views.
I'm still taking a moment to try to figure out where exactly the aneurysm is.
Okay, and I haven't given you any sort of CT to give you an idea. And these, like we talked about on Monday, sometimes you see all of these little double densities throughout these and say, oh, those little aneurysms, or is that just vessels turned back on itself? But there's definitely a couple areas that are clearly abnormal in this one. And I just actually gave away something that I didn't mean to.
On the image on the left for the M1 segment, there's a couple areas that I'm suspecting a little bit more laterally. So up top there,
Yes.
possibly yes, and then a little bit more laterally down there. Those are two areas. But then when I look over on the lateral view, I'm not as confident that those are truly aneurysms.
Yeah, so no, that's perfect. And this is where you're going to want multiple views, you're going to want oblique views, but that was perfectly looking at this. You got the vessel correct, you slowly identified what's normal anatomy, and absolutely this patient does have two left M1, so this is probably M1. This is maybe M1-2 junction here. So they were starting to go, same a little bit here. You're starting to go, remember we talked about out, up, out being the horizontal, the insular, and the opercular segments of the MCA. So absolutely two aneurysms. And this is where, and even now, like you can get really lost in the MCA, ACA area on a lateral. So let's follow it up together. So we got our ICA coming up, we got our petrous, our lateral, then we get into our cavernous segment through here, our clinoidal segment here, ophthalmic segment. Remember, now you also we talked about posterior communicating arteries. This one, you don't see a real robust artery here, so there is not a PCOM. And also remember, we talked about usually if there's a PCOM, you have a really robust artery splitting between the ACA and the MCA. We don't see that on the AP, so we combine those two things. There's not a good robust PCOM here. And then what we're going to do is we're going to get into this jumbled mess and try and make an idea of that. So you can imagine that sometimes I find it actually easier to start a little distal and trace back. So this is probably pericallosal right here. This would be our callosal marginal then up here. And you can imagine tracing this artery back right here. And that's going to be your ACA. So our ICA terminus is here. Then we know this artery coming off at that same place, that's going to be an M1. And you get to right here, there's a kind of a double density. And you see these little abnormalities right here and right there. And those are your two aneurysms. Very hard to see on a lateral. This is definitely one you're going to want to get oblique views. You're going to want to do a 3D spin to really assess the morphology of these aneurysms. But, you know, couple simple principles. What type of injection are we looking at? Looking at the AP and the lateral at the same time, and then trying to identify, so if you know what segment you're in, what direction they're pointing, it's really, you can get a good idea of, you know, what type of aneurysm you're at. All right. And then how about last one here, Emma?
Looking at this one, I think it is a right ICA injection.
Right ICA, perfect.
And going up on the P view, you do see that really dark spot, but
Yep. So what is that?
Cavernous, yeah,
That's
right.
your
So
cavernous.
that's not really an aneurysm. So if we continue on upwards, I'm not seeing anything like.
Yeah, you're not seeing a whole lot on the AP. All right. So I'm already giving you away that there's an aneurysm here. So let's, nothing's jumping out to you on the AP. So good. Now we're going to the lateral.
Lateral, you see it coming up through the cavernous, and yeah, that was just a double density. But then right about there, I think I see a blood.
Good. Superiorly. So what segment of the carotid is this? What vessel is this? Ophthalmic. Good. So ophthalmic segment. I like that you're saying the C6, but I'll be honest, I have to like when you say C6.
I was thinking about it.
No, it's okay. I always just, I think for MCA, it's easier usually to say 1, 2, 3, 4 because there's fewer segments, and there's really only one classification. There are several different, we talked about Flexure, several different classifications for the internal cervical or cerebral artery. So I would usually just say ophthalmic segment, but absolutely. And so yeah, so you have a superior pointing aneurysm, ophthalmic segment. What is it? The superiorly pointing ophthalmic. Perfect. A couple other things. I like this picture to show off or just kind of talk about. Any idea of what this is right here? Anyone? We can put this out to the audience.
Is like the clinoid of the
So this is going to be a cavernous segment. There are two branches. I wouldn't necessarily expect you guys to remember all of this. We talked about it briefly on Monday. Two segments or two branches in the cavernous segment.
Kind of like the vessels that surround the pituitary gland.
Perfect. Yeah. So this blush is the pituitary gland. That's perfect. And how do you pronounce your name? Is it Jan?
John, yes.
John? Oh, great. All right, John, thank you for piping up. I like it. And you are absolutely right. This blush is the pituitary blush. And this is your meningohypophyseal trunk. And this is actually a great representation of the meningohypophyseal trunk on the AP. You can see it here. Think about it. Pituitary gland is a midline structure. So it makes sense that it's projecting a little bit medial from the ICA. And then the other branch you don't clearly see here is your inferior lateral artery. But, and I'm not going to say for certain, but if you see a really robust, it's usually pretty straight artery coming off of here. That's going to be your tentorial artery or the artery of Bernasconi and Casanari. I think that's how you say those two names. That would be feeding like a tentorial meningioma. So nice. I like it, John. You got that one spot on. That's your pituitary gland. And I always think it's pretty cool when you can see the pituitary blush. Other things to note, I always find it helpful when you guys are learning angiograms, just take a look at the whole thing and say, you know, what are things that are missing here? Don't look quite normal. And it could be completely normal. So you may say, well, there's not really, you know, there's not much of an ACA. Usually you see an ACA. And yeah, this patient definitely has a hypoplastic A1, unless they're having a stroke, it was most likely that they have a dominant left A1 that then is filling both ACAs through the ACOM, which is also fairly common. Can't quote you the frequency of that. And then the other thing is you don't have a real robust artery flowing through here, so you likely don't have a PCOM. When you think about that, then your question is, well, what's this artery right here? You have an artery coming off of the communicating segment, like we talked about, but it's not a real robust artery. I don't clearly see a PCA. I think this is probably an anterior choroidal that is a pretty prominent anterior choroidal. So that's a nice one to see. It's nice to see when you see the PCOM and then the anterior choroidal state for sure, but it's always nice to look at some of the normal variants in a patient and not only get locked in on the pathology for an ophthalmic artery aneurysm. All right, so that's what I got for you guys today. I appreciate your all logging in, and